Hey, future doctors, and welcome back to Master Oral Pathology. Today, we're doing a high-yield clinical review on one of the most common and honestly downright frustrating lesions you're ever going to encounter in the chair. We are focusing our clinical lens entirely on immunologic diseases, specifically Aphthous ulcers. If you've been pulling late nights studying, well, chances are you or someone you know is battling one of these right now. They're notorious, they are exquisitely painful, and yeah, they're incredibly testable on your board exams. So grab your notes, get comfortable, because this masterclass gives you the exact framework you need to confidently diagnose, differentiate, and effectively treat these in your future practice. Let's just dive right in.
So just to put into perspective how prevalent this condition actually is, the literature shows the incidence ranges anywhere from 20 to 60% depending on the population. But what's truly fascinating here is the demographic breakdown. Canker sores are incredibly common among professionals, upper socioeconomic groups, super stressed out dental students, and, somewhat ironically, non-smokers. In fact, it's one of the very few oral lesions where not smoking actually puts you at a higher risk. That's likely due to the increased keratinization of the mucosa we see in chronic smokers. If you're sitting in a busy clinic all day, you're going to see this practically every single week. Understanding exactly what's happening at a cellular level is what elevates you from just saying, oh, it's just a canker sore, to actually providing true evidence-based care.
All right, here's our roadmap for today. We're following a strict medical model progression, which mirrors exactly how you should study for the boards. First, unlocking the etiology. Second, clinical features and variations. Third, histopathology and the immune response. Fourth, the differential diagnosis. And finally, number 5, treatment and prognosis.
Okay, let's jump right into Section 1, unlocking the etiology. Let's figure out what actually causes these persistent ulcers to show up in the first place.
You know, for decades, the exact cause of Aphthous stomatitis was heavily debated, but the core mechanism we now understand is that it's a focal immune dysfunction. Fundamentally, this is a T-cell-mediated condition. What happens is some initiating stimulus triggers a localized immune cascade. This often involves neurogenic inflammation, where a neuropeptide like substance P is just dumped directly into the local tissues. Think of this sudden chemical release like a flare gun going off, calling in an army of lymphocytes that indiscriminately attack the epithelium. The result? Focal necrosis. That necrotic crater is the exact lesion your patient is complaining about. Plus, there's a suspected localized defect in mucosal healing driven by the release of cytokines. So not only does the tissue break down super easily, but it really struggles to repair itself once the damage is done.
Now, while the underlying mechanism is an immune dysfunction, the actual spark that lights the fire varies wildly from person to person. Genetics play an absolutely massive role here. If both parents suffer from these ulcers, their kid has a staggering 90% risk of getting them too. And hey, definitely keep the HLA-B51 antigen in the back of your mind. That's a heavily associated genetic marker examiners love to test. Beyond genetics, we've got the classic triggers: psychological stress and mechanical trauma, like slipping with a dental mirror or just accidentally biting your cheek. Then there are nutritional deficiencies. Always consider screening for B12, folic acid, or iron deficits in patients with severe recurrent cases. Certain food allergies like nuts, chocolate, or gluten can also set it off. Oh, and don't forget toothpaste components, specifically sodium lauryl sulfate, or SLS. Honestly, sometimes just having a patient switch to an SLS-free toothpaste can be a total game changer that stops their outbreaks entirely.
Moving right along to Section 2, clinical features and variations. Let's talk about what you're actually going to see when the patient opens wide.
Okay, before we even look at the variations, I need you to burn this anatomical rule into your brain. This is a massive board alert. Aphthous are found almost exclusively on non-keratinized movable mucosa. We are talking the buccal mucosa, the labiomucosa, the floor of the mouth, the ventral tongue, and the soft palate. You will rarely, if ever, see a standard Aphthous ulcer on the attached gingiva or the hard palate. Memorize that. That strict anatomical distinction is literally the single most important tool in your diagnostic arsenal.
So, let's break down the 3 clinical variations using the rule of 3s. First, minor Aphthous ulcers. These are your garden variety. Small, less than ½ centimeter, they heal in 1 to 2 weeks, and they leave absolutely zero scar. Now, compare that to major Aphthous ulcers, historically known as Sutton's disease. Guys, these are the absolute beasts of the oral cavity. They are bigger than ½ centimeter, deeply crateriform, and just agonizingly painful. They can hang around for up to 6 weeks. It makes it incredibly tough for patients to eat, drink, or even speak. And because the inflammation destroys deep connective tissue, they actually heal with clinical scarring. Finally, we have the Herpetiform type. Now, don't let the name fool you. It has absolutely nothing to do with the herpes virus.
They're called herpetiform because they show up as recurrent crops of tiny ulcers, like 0.1 to 0.3 centimeters, looking super similar to a primary herpetic outbreak. But, just like the minor type, they heal in a week or two without any scarring.
All right. Section 3. Histopathology and immune response. What exactly is going on under the microscope?
If you were to actually take a biopsy of one of these, which frankly we rarely do, we'd see a highly orchestrated timeline of immune cell activity. In the pre-ulcerative stage, right when the patient first feels that familiar tingling, the submucosa gets flooded with mononuclear cells, predominantly CD4 helper T lymphocytes. But watch what happens as the lesion breaks down. Moving into the ulcerative stage, those CD4 cells are rapidly outnumbered by CD8 cytotoxic T lymphocytes. This CD4 to CD8 shift, it's the hallmark of the active ulcer. Board examiners absolutely love asking about this because it proves that the tissue destruction is actively being driven by cytotoxic T cells. Finally, in the healing stage, macrophages and mast cells move in to just clean up all the cellular debris and resolve the tissue. So, to sum up the histology, the microscopic findings are honestly pretty nonspecific. You're mostly just looking at an acute and chronic inflammatory ulcer with a fibrino-purulent membrane. But the crucial diagnostic takeaway is what is completely missing. There are absolutely no virus-infected cells present, zero. No viral inclusions, no multinucleated giant cells. Because the clinical presentation is usually so textbook, biopsies are rarely performed in general practice unless an ulcer is totally unresponsive to treatment and you need to rule out a malignancy.
Which brings us perfectly to Section 4, the climax of our diagnostic process, the differential diagnosis. How do we distinguish these from tricky lookalikes?
Okay, this is where the rubber meets the road. You have to draw a hard, distinct line between Aphthous ulcers and secondary herpes infections. Remember our rule? Aphthous ulcers heavily favor non-keratinized, movable mucosa, they are driven by immune dysfunction, and they appear strictly as ulcers from the very jump. They are never preceded by a blister. In stark contrast, secondary recurrent herpes lesions occur almost exclusively on keratinized, bound-down tissue, meaning the attached gingiva and the hard palate. Crucially, herpes is an active HSV-1 viral infection that starts as a cluster of fluid-filled vesicles before rupturing into painful ulcerations. If you lock in this exact clinical comparison, you will never get tricked by these two conditions again, whether you're sitting in clinic or sweating through a high-stakes exam.
Now, while herpes is the main differentiator, you still need to keep a few other ulcerative conditions on your radar. A simple traumatic ulcer from a sharp tooth or a bad bite. Incredibly common. For more diffuse or persistent ulcerations, you've got to rule out autoimmune vesicular bullous diseases like pemphigus vulgaris and mucous membrane pemphigoid. Cyclic neutropenia can also present with severe recurrent ulcers that sync up perfectly to drops in a patient's white blood cell count. And here's a really fantastic clinical pearl. If a patient presents with major, recalcitrant, aphthous-like ulcers that just refuse to heal despite aggressive local therapy, you need to zoom out. You might actually need to refer them for a comprehensive gastrointestinal workup to rule out underlying inflammatory bowel conditions like Crohn's disease.
Finally, we've made it to Section 5, treatment and prognosis. How do we actually manage this and get our patients out of pain?
Treatment for aphthous ulcers is entirely dependent on clinical severity. We use a very logical, tiered approach. Step 1. For the occasional minor ulcer, less is often more. Recommend no treatment or maybe just a bland sodium bicarbonate and warm water rinse to neutralize acids and keep the mouth clean. Step 2. For moderate, highly painful cases, we step it up to topical corticosteroids. Prescribing a fluocinolone gel or a dexamethasone elixir rinse blunts that localized immune response and gives them significant rapid relief. Step 3. For severe, unremitting major Aphthae, the ones literally stopping your patient from eating and drinking, we have to bring out the big systemic guns. This means a short course of systemic prednisone, usually 20 to 40 milligrams daily, carefully tapered over a couple of weeks. In some tricky refractory cases, systemic montelukast, a leukotriene receptor antagonist, can also be a highly effective off-label tool.
Now, here is a highly testable pharmacology fact you absolutely need to know. We can also use targeted antibiotic therapy, specifically tetracycline or doxycycline, deployed as an oral rinse. You might be thinking, wait a minute, why an antibiotic? You just told me this is an immune dysfunction, not a bacterial infection. And you'd be totally right. The magic of tetracycline rinses here isn't about killing bacteria. Tetracyclines uniquely and chemically speed up the mucosal healing process through the local inhibition of matrix metalloproteinases, or MMPs.
By inhibiting these destructive tissue enzymes, you basically stop the collagen breakdown and allow the epithelium to heal so much faster. It is an incredible, high-yield, dual-action therapy.
So let me leave you with this final thought. Tomorrow, when a highly anxious patient sits in your chair absolutely terrified because they have a painful crater-like lesion in their mouth that hasn't healed in 5 weeks, how will you use the criteria we just covered to confidently diagnose a major Aphthous ulcer, reassure them by ruling out a malignancy, and guide them to immediate relief? Master the mucosa, trust the cellular histology, and always rely on your systemic differential. Thank you guys so much for joining me today. Keep studying hard, and I will see you on the next clinical review right here at Master Oral Pathology.